Welcome to the Lipids Virtual Education Summit presented by Johns Hopkins University School of Medicine at CardioCare Live. My name is Dr. Chris Cannon, and you've tuned into a live session that we've entitled, Does HDL Matter? I'm joined by my friend and colleague, Dr. Jorge Plutsky. He's the director of the Vascular Disease Prevention Program and also the Lipid and Prevention Clinic at the Brigham. I send him lots of my tough patients. And also heads up the Brigham and Partners Premature Atherosclerosis Center, all at Brigham Women's Hospital here in Boston. He's an associate professor in Harvard Medical School. Now, his other work is that he directs a basic science laboratory, investigates mechanisms contributing to the development of atherosclerosis and other metabolic diseases, including diabetes. And so he's really the perfect person, and the person that we turned to at the Brigham after the AIM High results came out, and we said, okay, what about HDL? Please help. He had a packed room of the cardiology conference, and we've invited him here to go through this topic of what about HDL, and more has happened since then. So before we get started, I'd like to remind our audience that we'll be taking questions real time during the presentation. You type them into the box with questions, and they come to my laptop, and I'll be trying to get to as many as we can, posing them to Dr. Plutsky. So hopefully we can make this very interactive. And so with that, I want to welcome all of you, and we'll hear about, does HDL matter?
Thanks, Chris. Well, one of the inducements to doing this is a chance to have a conversation with you, since we tend to be too busy in the hospital to ever sit down and really think about these things. So I welcome the chance to talk about the data and to hear your takes on it. And together, maybe we can answer this question definitively today, although I think we're really in need of more data. And of course, I think what's obvious to all of us in practice is the motivation for this is that if we look across the statin trials, we still see residual risk. We still see patients having events, and there's a need for further intervention. And of course, there's been a lot of interest and focus on HDL as a prospect for that, and it may be particularly an issue in patients with diabetes, which has been a particular interest for us. So even if you look at the 14 statin trials, the patients with diabetes who get treated still end up with event rates that are higher than the people with no diabetes who got treated. So we really have other issues here. And I think at the end of the day, there are many strategies that might get at that residual risk, but we'd like to think that we can still do better, and we can do better therapeutically. And it's inevitable that attention turns to HDL. I mean, we have a steeper curve in terms of the relationship between HDL levels and CHD risk. We have a curve that's steeper than it is for LDL. One sees a bigger gradient of risk associations with HDL than you'd see with LDL, and it is a very robustly identified epidemiologic relationship that HDL has this inverse relationship with risk. And that, in fact, has in general not been called into question, although I'll point to some data at the end that may provide us some suggestions. And in terms of the mechanisms of what we think is going on there in terms of lipid metabolism is a fundamental separation between all the lipoproteins that contain apolipoprotein B, ApoB, which we think is pathogenic. LDL is one of them, but of course VLDL and intermediate density lipoprotein IDL is another one. And distinct from all those ApoB containing lipoproteins are the ApoA1 containing lipoproteins, which is predominantly HDL. And we think that, and have thought that given that epidemiologic relationship, that there were aspects of this HDL and ApoA1 that were atheroprotective and might have other mechanisms of action. And so, here's the object of our attention today, where we're going to, and the object of affection for many people, trying to sort out the potential for improving outcomes by manipulating this heterogeneous molecule, like all the lipoproteins, that has on it this zip code, as I like to refer to them, of apolipoprotein A1. And this HDL showed up early, showing a relationship with the risk. This is the Framingham Heart Study data, which I think is quite compelling, because we can now, with as much information as we have about LDL in different clinical scenarios, including seminal studies by Dr. Cannon and his colleagues, we can look at these numbers and say, well, let's look at an LDL. And if you look at the LDL of 220, you'd say, well, that's a very high LDL. But look what happens as you hop down the HDL scale. An LDL of 220 is a much more worrisome parameter when the HDL is 25. So it's not like the LDL of 220 creates a certain level of risk and it occurs across the board independent of HDL. You still see a risk relationship there. Now 160, which is pretty close to the average in the US, we see a stepwise relationship. But even with an LDL of 100, we say, well, here's a lower LDL. One again sees this gradient of risk that segregates according to HDL. It's very provocative. It suggests that it's exerting a relationship there. Now, in addition to Framingham, there's other studies that really pointed to HDL that have stayed with us, and this is a well-known one, often cited from Jacques Genet, who asked a pretty simple question: what do you find when you go around and look at patients who have had premature cardiovascular events, who are young, who are men, 50s and lower? What do you find? What shows up there? And one of the things that shows up, adjusted for other parameters, is a low HDL, and that's a very common scenario in the young patient having an MI. It's very often a low HDL that's part of their picture. That, of course, is not just in those young people having cardiovascular events. It's actually quite common across the board in the US. So this is NHANES kind of data looking at the frequency in the population of low HDL in men and women. And the numbers are laid out here. And so it is not an uncommon scenario. And in fact, HDLs less than 20 showed up in this particular data set at 1 in 200 men, 1 in 400 women. And some people have a very low HDL. And so these questions come up for clinicians all the time, especially as we do more lipid screening now.
I think looking at this, these are, as it's segregating out, there's sort of two categories of HDL where you worry. Sort of it's a little bit low, it's 35, and that's unfortunately very common. And then these other patients where it's super low.
Very low. And
those are the ones where I quickly sell and say, oh, you've got to see Jorge.
Well, and I send it back to you maybe with no more insight, but it does come up, and we see it quite a bit. And of course, we see it in patients with metabolic syndrome and diabetes. And so what does that mean, and how does that influence the clinician who's seeing these patients? Well, you would think that it's ultimately related to what we now know about HDL and what they do functionally. And of course, the shorthand for that we've all learned in medical school is that it's reverse cholesterol transport, that this HDL molecule, when secreted, it emerges as an ApoA1, really pre-HDL, and it's a flat disc that has very little cholesterol in it, and that ApoA1 will come up against the wall of the artery or any place else in the periphery and allow cholesterol to be taken up, and the disc goes from being a disc to being now a fuller particle, detaches and heads back to the liver. And so there you've already instigated reverse cholesterol transport, because you have a particle that's going to go out in the periphery, pick up cholesterol and take it back, and is what we associated with all the protection that seemed to exist in epidemiologic studies when the HDL was really high. It's interesting that for very high HDL levels, which is hyper alpha lipoproteinemia, there's even data that suggested longevity and maybe protection against cancer.
Well, that was actually one of the questions from Anna Gershunova, asking, what about people with an HDL over 100? My mom is one of them, and have asked, do you then live forever, or do you get a little benefit out of that?
Well, among the various answers that we might give today, one of them I'd be able to say more definitive than anything else I'll say is no, you don't live forever. So I remember that. The data for that is very strong. But there is a suggestion of perhaps longevity and protection. Now, some of that data came from founder effects in populations where they had very high HDL levels. And I think the cancer story is still not clear, but I would say clinically, we don't let a very high HDL keep us from treating. So I would still base treatment decisions on overall risk and the LDL. If you go back to other data sets, events still happen in patients with a high HDL. And as a matter of fact, last time I was on service, we admitted someone who had a very high HDL who had not gotten treatment from their PCP because they assumed protection of this very high HDL, and there he was, in having an acute coronary syndrome in the setting of hypertension, and a man in his 70s, and so you just can't assume that, and I think that remains valid. And of course, the HDL not only participates in this reverse cholesterol transport, there's been a lot of interest in other things that HDL might do given this relationship, and there's been many of them suggested that it could be anti-inflammatory. There's quite a bit of evidence for that. We've studied that and have shown the same kind of inhibition of leukocyte adhesion to endothelial cells through HDL. It may limit thrombosis. It may help with the repair of the endothelium. There's lots of different effects that have been raised about HDL. One notion that's pointed to it is looking at the statin trials and the evidence that it has not always been clear-cut about whether or not the HDL matters of how you're going to respond to statin. And so here's TNT data showing a relationship there, a gradient of risk based on quartiles of HDL. And in contrast, here's the subgroups from 4S that said that your HDL levels didn't matter in 4S, with LDLs in the 190 range. Getting a statin, in this first landmark trial, that when you looked at the HDL subgroups, it didn't predict. But here's AFCAPS, TEXCAPS at the other end of the spectrum, primary prevention people who didn't have an event and who, importantly, there was an HDL cutoff. A lot of people don't remember about AFCAPS, TEXCAPS. You couldn't get into this study if your HDL was too high. And there was a significant difference based upon HDL levels there, as if the statin was offsetting some of the risk associated with HDL. So, to your point, Chris, if you look at that subgroup of HDLs less than 34, you can see the relative risk reduction from getting the statin in those folks was even greater than the people who had higher HDLs. It still worked for both of them, but it's suggestive. I won't go through this in detail. There have been many gene variants that have been shown to be related with it, and are interesting in and of themselves, like Tangier's disease. From Tangier Island off the coast of Maryland is where a defect in ABC1 was found. The relationship between Tangier's and coronary disease has been, not clear-cut. You would think like, oh, it would be obvious. These people have, a very low HDL. They're going to have a lot of atherosclerosis, but the amount of cardiovascular events they've had seems disproportionate to their low HDL. And interestingly, some other variants can be associated with a low HDL that seem to be protective, like ApoA1 Milano. There's actually, in people from Milano who have that variant, their HDL levels aren't 100. They're actually on the low side, but they seem quite good at effluxing cholesterol out of the plaque.
It's interesting. One of the viewers asked, what about the size of the HDL?
Yeah.
You mentioned the discs are the small ones, and that used to be HDL-C, and I forget
1, 2, and 3, and that still gets some attention, and especially now that we're trying to sort out some confusing data. And so I think it's just, the jury's out, and it's not clear that the subgroups of HDL matter, but maybe that's going to be one way to try and explain differential effects. There's been the suggestion of different effects on HDL subgroups, like in response to alcohol, as something that can raise HDL. Importantly, there's lots of secondary causes of a low HDL, and these are quite relevant because given the fact that we know that some of these lifestyle changes can improve outcomes in general, maybe one of the ways we're doing it is by raising HDL, and I think it's important not to ignore this. And that would even extend to patients who are getting a beta blocker whose HDLs come down significantly. If they're getting the beta blocker just for hypertension, but haven't had a cardiovascular event, maybe it's not the first choice in those folks. And interestingly are some of the genetic defects that cause high HDL, which have not necessarily been shown to have protection against cardiovascular disease as well. Also controversial, and I'm going to show an example of that at the end. And we do think that there's a variety of aspects of lifestyle that can raise HDL. Also been discussed back and forth quite a bit that, does it require really Olympic level exertion to really raise your HDL? And there have been a couple studies suggesting that may not be in some subgroups, like older patients with diabetes, that you really don't have to become an Olympic athlete to really raise your HDL.
Well, that's good, because this is a question Peggy Burr asked here, and I had thought that you had to really
that's what we used to think.
do more than I do in the gym to...
I think it depends on where you start and what's your metabolic status. And I think one of the most impressive things that one sees clinically is in patients who are overweight, who have a high trig and a low HDL, how much better things get with modest amount of weight loss. Really dramatic changes in triglycerides and HDL and things like CRP and prediabetes as measured by, let's say, an A1C. We often see patients coming back to the clinic with 10 pounds of weight loss and gosh, things look dramatically better. Wow. And I think that's different than the average patient whose HDL might have been at 40, 45, and it probably takes a lot of exercise to really change your HDL level in that kind of scenario, but not if you've got metabolic issues and abnormalities. And it is an interesting clinical observation that's fun to watch in clinic, is that when the trigs are high and you bring the trigs down, the HDL is often going in an opposite direction with the triglycerides.
Well, it's encouraging on the exercise.
Yes, exercise works for many different things. So what about targeting HDL and what about treating it? Well, we've just talked about this, about lifestyle, and there's the suggestion that losing weight can raise your HDL. It is influenced by where you stop. Smoking raises triglycerides and lower HDL, and we certainly think that stopping smoking is a good idea. Maybe some of it is through HDL. And then exercise can increase HDL, and how much is also, we were just talking about. And there is the suggestion that maybe some of these parameters may change HDL in a way that we're not replicating with the drugs. So I don't think we've abandoned these notions that these kinds of interventions are valuable. Whether or not they're values because you've raised HDL is not clear, but I don't think that's off the table either. So here's a list of the drug effects, and certainly number one in the category is niacin. It has the biggest effects on raising HDL of any drug we use. Fibrates will raise HDL as well. We use them perhaps more often when the trigs are elevated. There had been interest in hormone replacement therapy as perhaps raising HDL, but then the trials have been negative, maybe because of offsetting other issues. Statins tend to have a modest effect on HDL. Alpha blockers are on this list, and alcohol I mentioned.
One question came in about, are there differences amongst the statins? Someone was asking whether simvastatin makes the HDL go down. I know rosuvastatin is touted to have the biggest effect, and some studies it has a bigger effect than others. Is there more of a class effect or some differences?
I think that where one sees the biggest differences in the data that's available is when you're talking about at the highest doses. So I think atorvastatin at 80 probably has the least effect on HDL, HDL raising, and it might be in the 3 to 4% range. Whereas rosuvastatin at its highest doses may have the best effect on HDL. But at the lower doses that most people are on, it doesn't really, there's not huge swings there. And we know that atorvastatin at 80 milligrams has significant clinical benefits in trials. And so you could say, well, independent of that, maybe the HDL in those scenarios don't matter. Certainly we follow clinical trial advice, and based on prove it, patients at Brigham are appropriately getting atorvastatin 80 milligrams. They're not thinking about that. But a patient is 4, 5, 6 years out, that one might look at an HDL on atorva 80 that's on the low side, let's say it's 30, and you might ask if it's possible to approve, what would your numbers be like on rosuvastatin?
Yeah.
And we will often do that, and often then, you know, in a version of personalized medicine, with all things being equal, say, you know what, you had a better HDL response on this drug versus that drug, and then go with that. But it's a pretty empiric approach, you know, and still using the trials to guide us.
Yeah.
And here's some data just showing you what niacin does to HDL, and it can, in this particular study, the increases can be quite significant. It also lowers Lp(a), which I'll come back to. And the reason why so many people are so interested in niacin, because if you look at this, it's doing everything in the right direction. We used to say, you know, it's the best drug you're not using, you know, because of the tolerability issues, but everything's going the right way. And the interest in niacin was fueled by some of these smaller studies, like Greg Brown's study showing when you combine niacin with simvastatin, there's a big reduction in HATs on outcome, and it led to lots of interest in this possibility, but this is, of course, a smaller study.
You know, going back it looks like there's a pretty strong dose response on the prior slide there. You know, knowing that tolerability is sort of the struggle that, you know, everyone can get on 500 usually and 1,000, but then when you start to push to 1,500, 2,000, I don't know if I've ever seen anyone on 3,000.
Well, this is in a particular preparation.
But yeah, exactly. But it looks like there you know, it's a big difference in how much HDL you can get or LDL.
Yeah, well, we certainly in clinic will be pushing people to 2,000, and we also have, you know, tend to know, I think, for people who do this, who's going to tolerate niacin, or who's even a good bet on that. And it tends to be a patient who's very compliant, because when you miss a dose, the side effects that you grew tolerant to will often come back. So, you know, someone who's not very compliant with their meds is probably not going to do great on niacin, because they'll take it for a couple of weeks, then they'll stop it, and then they'll try it again, and they're going to go back through the flushing. Whereas the patient who's very compulsive about never missing it, who takes aspirin a half an hour before, doesn't take hot liquids like tea before they go to bed, or alcohol that promotes the flushing, they tend to do better. And for many of those other patients, we won't try it. And of course, that baggage also includes, you know, potentially bringing out gout and worsening insulin sensitivity, which can also be issues with niacin. So, you know, it does have issues, but the dose could be quite relevant, and is relevant to some of the efforts, both in the past and still in the future, of let's just block the side effects, and then maybe we could get the dose up higher, which was a strategy for at least one failed drug. Now, another interesting bit of data that supported this concept is the Coronary Drug Project, which had one of many arms included niacin. When the study was stopped at 6 years, there was not a difference in events, but very interesting, at 15 years of follow-up, independent of you're taking the niacin or not, there was a survival benefit for having gotten the niacin. So, you know, we don't do 15, 16-year studies, but maybe there's something, you know, to this, and this has been raised in the diabetes field as well, this legacy effect. Now, more recently, we've had trials that have really questioned niacin. Aim High was looking at Simva versus Simva plus niaspan with a variety of issues in the trial. A little bit of niacin was given to the Simva group to try and mask side effects that would have unblinded it. There's also a mix in here of ezetimibe for people who didn't get the goal. And it wasn't a very big study, but HDLs went up and events did not come down. And so lots of questions about Aim High, but it certainly was not very supportive given the fact that HDLs did go up and there were events and we didn't see a difference.
And I think the difference in HDL that they were able to achieve was kind of modest.
Maybe because of this, you know, small amount of niacin that was given to the control group.
Yeah, it was a fascinating thing that, you know, I heard sort of on the 4th or 5th presentation that they sort of stumbled on that as a possible explanation.
And whether that's true or not is not clear. Then, of course, HPS2 Thrive was another shot across the bow of niacin, an attempt to block side effects with loperant while giving niacin. And this, in 20,000 patients, also did not show a difference in events. And so also further questioned, well, in patients who can get their LDLs down into the 70 range, which these studies had, that maybe you're not going to see a difference. So one of the other possibilities is CETP inhibition, and the CETP plays a role in transferring an exchange between the particles, and we've had several of these come up. Two of them abandoned, torcetrapib and dalcetrapib. Anacetrapib and another CETP inhibitor are still, of course, in the game. Torcetrapib showed very significant increases in HDL, but worse outcomes. And so it really gave people pause adding the CETP inhibitor to atorvastatin. And maybe, has been raised in an explanation, maybe it was an off-target effect of the blood pressure. So anacetrapib, of course, as Chris knows well, is leading a study around this, not only raises HDL significantly, but also lowers LDL, and has raised the possibility maybe that's one of the reasons why anacetrapib might go forward and show us a difference. There have fortunately not been effects on blood pressure, which is very encouraging compared to the torcetrapib. And we have early safety data from Chris that raises this possibility that maybe this will be an alternative for us. And HPS3 TIMI55 Reveal is studying that, right? And you're well underway.
Yeah, so this is nearing completion of enrollment, but then, as noted, the median follow-up planned to be 4 years. So these experiments are long-term.
Yeah.
In part with the novel mechanism, one doesn't know how long it might take before it starts.
Separate.
With statins, we've seen, most of the usual trials takes like a year or so before anything really starts to happen. So it may take a while.
Well, also on that list, beyond the CETP inhibitors, has been this longstanding interest in PPARs. And we were quite involved with this story in the laboratory, showing that the PPARs as nuclear receptors were expressed in vascular and inflammatory cells, and it raised this possibility that when you activated PPARs, you could have metabolic effects that might have benefit. You also could have direct effects on the vasculature. And PPAR gamma agonists, of course, are thiazolidine diones, and PPAR alpha agonists are fibrates. In VA HIT, we had a positive trial with no statin use, and this was, the HIT stands for HDL intervention trial, and so giving gemfibrozol to 2,500 veterans who had LDLs of 111 and HDLs, a baseline of 32, modestly elevated triglycerides in the 160 range, who at the time, even though they had cardiovascular disease, did not have to be on a statin. So here's a fibrate alone, and it shows benefit. It's a positive trial, and events were down. And interestingly, the events seem to be really driven by the outcomes in patients who had diabetes, the very people who often have lower HDL and higher triglycerides. So there was a lot of excitement about the idea that maybe fibrates should be first line in diabetes, and the field study was nothing but patients with diabetes getting a fibrate, a once-a-day fibrate in the form of fenofibrate, and that was a negative study. The primary endpoint didn't show any difference in terms of CHD events. There are subgroups that do show benefit, like non-fatal MI was down, cardiovascular events, coronary revascularization was down, CHD death was up. And so that's the issue with the secondary endpoints, but that was disappointing.
And this was on top of a statin, I think, was the sort of...
Yes, well, the question...
No, sorry, this is without...
Pheno alone.
Yeah, but the drop-in
rate,
statins,
yeah. So one of the concerns in this particular study was that there was a disproportionate penetration of statin use in the placebo group. Yeah. And, there's a lot of data coming out for statins at the time. And sometimes fenofibrate will have a modest effect on LDL. And so I think that, patients who came back in for follow-up there, the doc would look at the LDL and say, I just don't like how this looks, and added a statin. Yeah. Whereas maybe they weren't as inclined to do that in people getting the fenofibrate because of this modest LDL effect. But you most likely eroded risk in the placebo group, so you couldn't see the difference. Yeah. But it's only a theory and a hypothesis. Yeah. And none of these studies address what happens when you combine the two, add a fibrate to a statin. And that was a cord lipid. And importantly, here are the numbers at baseline: LDL of 100, HDL 38, trigs just 160 range. Another negative study, no difference. And a lot of attention is pointed to the fact that when you look at the subgroups, where you do see a difference is in the higher trigs and lower HDL. That's where things move off that identity line. And this makes sense to me because if you came into our lipid clinic with triglycerides of 160, I'm probably not going to give you a fibrate. I would give you a fibrate if your trigs were significantly elevated. And that's where the subgroup data seems to point to, especially in the statin era. And it actually lines up with other fibrate trials where there's also this suggestion, it's not definitive, but that where you really see the benefit is when the trigs are significantly elevated and the HDL is on the low side. That in the post hoc analyses that are looking at this, that you can see the bigger bang for the buck in those kinds of settings.
Yeah, this is pretty dramatic consistency,
Yeah,
which is
yeah,
what we
it
always
lines up.
look for.
Yeah.
And I guess they did pre-specify that combination. What is it about the biology of that group
Scenario.
that's sort of the metabolic syndrome type
Yeah.
patient?
Well, you know, it could be multifactorial. The fact is that when your triglycerides are elevated, most of your LDL is small and dense. And there's a lot of things that track with those triglycerides being elevated. And when your HDL is low, you could have altered some of these other functions of HDL and also have an effect on the ability to efflux cholesterol. And we've known for a long time that it's a particularly bad triad at a given LDL to also have elevated triglycerides and low HDL. And all these particles communicate with each other, and we think smaller, denser LDL is going to be more atherogenic, more prone to oxidation, more likely to get retained in the arterial wall and set off this cascade of reactions. And the fact is that idea of smaller, dense LDL is what you try and get at when you calculate a non-HDL. You're trying to measure the ApoB levels. And if you have lots of small, dense LDL, your ApoB level is higher because each particle has one ApoB on it. So when you calculate a non-HDL, you're getting a measure of ApoB. When your trigs are elevated, you're probably going to have smaller, denser LDL particles. So maybe that's part of what's being shifted there.
Yeah, I mean, this does seem like it's sort of the group where it's the high-risk lipid group.
Yeah.
You know, elevated LDL we can handle, and then sort of the next big problem seems to be this combination that
higher
unfortunately
trigs and lower HDL.
is relatively common.
Yeah. Well, so fibrates are thought to be PPAR alpha agonists. We also have data around PPAR gamma, which gets relevant. And of course, rosiglitazone, very controversial about its effects on cardiovascular events. We just had the FDA, have a panel revisiting the rosi data because it's far from definitive, suggesting that maybe the risk there has been overstated, but certainly we've not seen clear-cut benefit, and unfortunately we didn't have a clinical trial. And rosi seems quite different than pioglitazone, where we did have a prospective trial in proactive with perhaps a poorly chosen primary endpoint that included many things, including vascular disease, peripheral vascular disease, but a secondary endpoint that was a more traditional kind of cardiovascular endpoint that was going in the right direction and was felt to be positive, 16% reduction in patients with diabetes. But it was a secondary endpoint, and you got to call your shots. And but it had been a lot of interest in pioglitazone, and interestingly, in Periscope, which was looking actually at coronary atherosclerosis, IVUS showed a decrease and no progression, which was what was seen in glimepiride. So these are human coronary arteries that have less atheroma volume in response to pio. And if one looks at both in this study of coronary atherosclerosis and also a carotid thickness study called the Chicago study around the same time, and says, okay, why? Why is pio having these effects? One of the parameters that's changing is HDL. And subsequent follow-up studies with pioglitazone suggested that the benefits accounted for by the increase in HDL. So here in Periscope, the upper left-hand corner, the HDL increase is shown there as 16% with a pio. And in fact, rosi doesn't have this kind of HDL effect. And the reason why that's relevant is because we have a late-stage trial that's also going at this. There's been some suggestion that pio has PPAR alpha activity. We showed that in preclinical models, but there's always been this notion that pio may be different because it has some activity on PPAR alpha. And there's lots of data to suggest that PPAR alpha may have benefits, PPAR gamma may have benefits. And so what's the potential to combine those in a single molecule with a dual alpha gamma agonist? And aliglitazar is one. We've had many come along before this that did not make it for various reasons. But aliglitazar has gotten pretty far along. And here's the safety data. in the Synchrony study published in Lancet that encouraged them to pursue this, this combination of a PPAR alpha activator, which is going to lower trigs and raise HDL, and PPAR gamma activator, which is going to insulin sensitize. And so this data is comparing it to PIO at its highest dose of 45 milligrams. And you see, better A1C reduction, greater triglyceride reduction, and more HDL increase.
I mean, those numbers are, that's about the best that niacin at its top dose would get, and obviously the hemoglobin A1C is going the
down,
right
as we see with insulin sensitizers.
Yeah.
So, I think the reason why we pay attention to this is because of the, studies like AlloCardio, which is looking at alloglitazar in ACS. Patients with diabetes who've had an event who get randomized now to their usual treatment of their diabetes versus alloglitazar. And it'll be very interesting to see the results of this study that's fully enrolled. Now, myself, I wanted this trial to have a triglyceride cutoff where you couldn't have you forced the study to have higher trigs, because I'd hate to see AlloCardio be neutral, not showing harm, but having benefit only in the high trig group and the low HDL, which we've seen before. But there are challenges, of course, with recruitment when you keep putting in more and more barriers, as you know better than I. Right. And importantly also is that the PPAR gamma agonists have had issues with fluid retention, signal in bladder cancer, which is debated, but they do cause weight gain. And there has been a small signal on bone fractures. And so AlloCardio can be positive, but it's going to be a question of what else came with it. Right. But if you're having benefits in ACS, maybe that's going to offset those concerns. Now, I think as we try and resolve this, there's more and more data coming out, and I think some of it's quite interesting, and this is from our Harvard colleague at the MGH, Katharesan, where using a genetic epidemiology approach in a large cohort, some 21,000 MIs, compared to 95,000 controls, they looked at genetic variants. And looking at those, you see some interesting observations. For example, genetic variants that led to a loss of endothelial lipase, which had been considered and is still being considered as a drug target, raised HDL. You'd predict, based upon the epidemiologic data, that they should have had about a 13% decrease in cardiovascular events. And in fact, what they observed in this large study was no difference. And I think that maybe one notion that may be at hand here is that we have to understand better what the HDL is doing, and that if you could identify properties of HDL, like its ability to efflux cholesterol, that maybe you would have better ways to pick drugs. And maybe CETP inhibitors end up with a HDL that's not so good at effluxing cholesterol, even though the levels are high. That an endothelial lipase loss of function results in an HDL that's lost other characteristics. And cholesterol efflux is one of many parameters like inflammation, nitric oxide, thrombosis, and characteristics of HDL that you raised, such as particle number, but also the proteins and their state within the HDL. That could all be variables that we haven't yet thought about that could end up explaining.
Yeah, I mean, it does seem that this is more complicated than LDL, where you got bad stuff, just get it down. Here, the HDL particle has to function. It's got all the different components. And, I mean, on the efflux, that does seem to be a focus of attention now, of rather than just measuring how much HDL, how good is the HDL?
Yeah, and doing its job.
Yeah.
Especially when you look at some of these variants in which people don't have very high HDLs, the efflux is very robust and they seem protected.
Yeah.
So, I'd conclude, the simple conclusion is, does HDL matter? I'm going to say yes, because I think it's predictive. I think if I saw a patient in clinic and the HDL is low, I'd pay attention and think to myself, is this person at higher risk? Because that HDL does remain predictive of risk. The lifestyle improvements, I think, are valid and beneficial across the spectrum of issues like cancer and other issues you wouldn't think would correlate with exercise, but seem to, and may be associated with changes in HDL that are beneficial. But that's tempered by the fact that HDL raising interventions are really unproven as a strategy at the moment. We've had studies with niacin that have not brought home the evidence, and we use less of it now than we did before. fibrates, I think, still can have a role in that subgroup, but patients will know, and I'll explain it to them that I'm doing this based on subgroup data, that I can't tell them for sure it works. But if a patient's having a cardiovascular events and they're in those high trigs, low HDL group, I'll still use a fibrate, and fenofibrate is our preferred one because the gemfibrozole has more drug-drug interactions. It's twice a day. And with all that being said, there are patients in clinic where we're certainly not calling in patients saying you got to come off your niacin. And there's some patients who will come into clinic and we'll leave them on the niacin, or even think about starting it. And what are those situations? Well, in patients who have cardiovascular disease and have a very low HDL and elevated triglycerides, it can be a possibility. We've had patients come into clinic who have had a 20, 30, 40 point increase in their HDL. And it's like, are we going to throw that back because we don't think it works? And then in subsets of patients who have elevated lipoprotein little a and who responded, because a lot of patients won't, but if you got the niacin for an elevated LP little a and it came down and you tolerated it, that would be another setting in which we would say, well, we don't yet know the LP little a subgroups in those studies, and those numbers are probably going to be low. If one of these drugs works that lowers LP little a as the CETP inhibitors can, then I think we'll start to see trials of just people with LP little a elevations. But it's probably, every clinic I will have, often one patient with a strong family history coming in whose LP little a is, quite elevated, asking what to do. Yeah. And we don't have good answers for them.
Well, this is a tremendous review, and thank you. This is sure. Exactly why we have you in to share. It does seem that the concept, this is easy, let's just add it, raise HDL, it's mom and apple pie, yeah. That sort of era is done. Yeah. But it did seem in a lot of the discussion after HPS2 Thrive that people were focusing on people with lipid abnormalities, yeah. Not just the whole world. Yeah. You had presented some cases of the yeah. young guy with an HDL of 20 who yeah. you got it up to 40, and yeah. you're like, yeah. that's probably good for you.
You would think, but it's still the possibility that the HDL is just a biomarker for other things we were doing. Yeah. And that maybe it's not conferring benefit, but it is a hard thing to throw that back, to tell the patient to come off of it. Yeah.
The other thing I've taken out of the trial so far, and it's a little bit like the early cholesterol-lowering trials that use the resins, is that if the lipid effect is modest, the yes. clinical effect yes. is often modest. And yeah. so even though they would try it, I actually don't know in HPS2 Thrive what the mean dose of the niacin lapriprant was. Yeah. But I think they had like a 12% raising in HDL, which yeah. like is not that much. Yeah. 6 points or right. something. And would it take, big changes yeah. in order to get,
right. Well, hopefully, given, it's not a small study that we'll see that. Yeah. It'll be post hoc, but is there a difference for the person who really got their numbers up? Yeah. In aim high, the HDL changes were not small. I think on the order of 20%. Yeah. And there were events, and we didn't see a difference there. But maybe it was muddied by all these other parameters, and the study wasn't that big. Right. So we're left with questions, and I think for the doc sitting across from a patient whose HDL is low, we unfortunately still have some unanswered questions. I mean, one strategy in those folks, if you're concerned enough about the niacin, if the trigs aren't elevated, if you're not going to do the fibrate, if it's primary prevention, is that separate from lifestyle interventions in patients who've had events is, perhaps running the LDL lower. And that's what we've done with a lot of our LP little a patients who can't tolerate the niacin, or, as is often the case, just didn't get a budge with their LP little a, is we'll say, well, you know what, you've had cardiovascular events, instead of running you at 70, we're going to try and run you at 50, right. trying to offset some of that HDL.
Right. One person asked, given all this, is high HDL bad for you?
Yeah, yeah, that comes up. I just had a patient in clinic who came in because her HDL was 120, and was concerned about that. And Again, I'd fall back on the epidemiologic data that says it's not, and that maybe you're lucky, and maybe you're hyperalpha lipoproteinemia, and maybe you're going to have some protective effects from that. I would not look to say, oh, I'm going to have to use a statin therapy, or try and find some ways to get the HDL down, or that it's a biomarker for people who have an issue. I just don't think we have that evidence.
Yeah. Now, what about in the high trigs, low HDL? The fish oils have been used at high doses to get the trigs down. They don't do much, I don't think, on the HDL.
Yeah.
Is that something one should think about in this combination high trig, low HDL, or should we really go after fibrates and niacin?
Right. Well, it's an interesting issue, and we still see lots of activity in the triglyceride fish oil space. There are 2 prescription forms of fish oil, and then there's over-the-counter fish oil. The 2 prescription forms have a difference between them in terms of the major omega-3 fatty acid that's in them. We had some encouraging data from GISI saying that fish oil made a difference. Then we've had some disappointments, recent studies with the Origin, and some other studies that have raised questions about the fish oil. And even the mechanism, there had been a lot of suggestion that the benefit was on arrhythmia, and that the fish oil is getting interspersed in the membrane and changing arrhythmia thresholds that may be less athero-based. So how we factor that in is a patient with very high triglycerides who are on a fibrate and we can't get them down, we'll add in fish oil as the next step after we've done secondary causes of high trigs and lifestyle. Some patients don't want to do the fibrate or are hesitant about the fibrate, or it's primary prevention, and so there's some hesitation of, well, why add the fibrate here if you're on a statin? And for some of those patients, fish oil, I think, can be an appealing alternative. We tend to use the prescription forms because the over-the-counter fish oils are highly variable in terms of what they fed the fish to get the oil up enough. And there's lots of discussions about that, or some of the fish oils that, like, for example, that come from krill, maybe they're better or not. But there are patients where we're not looking to add a second drug, where sometimes fish oil is an alternative. And I think it's also appealing sometimes in patients who just don't eat fish. You know, you have a patient whose trigs are 300, and you say, how much fish do you eat? And they say, none. You say, well, maybe I'm going to give you back something that would be better if it was in your diet, but you're just not going to eat fish, so you're not going to eat fish, so let's try fish oil.
All right. A final question. Someone asked about a drug that elevates LCAT in the liver. I don't know what that is. And it raises the question of, are there other classes of drugs coming along in this space of raising HDL or that combination lipid group?
Yeah. Well, some of those broad-based genetic studies are identifying completely new targets. And so I think we'll see more of drug candidates coming along that will be based hopefully on greater insight into mechanistic aspects of this. And the fact is that metabolism of triglycerides occurs by predominantly lipoprotein lipase. And the natural inhibitor of lipoprotein lipase is a protein called the ApoC3. When you have high ApoC3, you have less LPL activity. LPL is this essential enzyme that cleaves the fatty acids off of triglycerides so that you can use them to burn, because the fatty acids are this incredible energy resource. So when you exercise, and knowing Chris, you exercised this morning, and when you did that, you don't have to answer that.
I did, actually.
See, there you go. So what did you burn to move your muscles? It was a fatty acid. And the lipoprotein lipase takes those triglycerides, cleaves off that fatty acid, and takes that fatty acid, which is really like an oak log, and lets you put it into the furnace of your muscles, beta oxidize it, and generate 9 kilocalories of energy for every, for burning the fatty acid in terms of equivalency compared to glucose, which is less than half that. So it's a preferred energy source and substrate. Lipoprotein lipase is an essential part of that. When people start to exercise, they induce lipoprotein lipase because you need it, right? You got to burn the fatty acids. That's how you get at it. So if you have a high ApoC3 levels, you inhibit that. And so there's an example where people are starting to wonder about ways where you could knock down ApoC3 and let the LPL be active. Your trigs would come down, your HDL might come up. And in fact, some genetic evidence argues that people who have a gain of function of LPL, which exists, those people tend to have low triglycerides, higher HDL, and look like they don't get much athero. So maybe we'll see other therapies. Whether or not LCAT will be among them isn't clear, but there's certainly people interested in it.
Well, this is just terrific. You know, it's a fascinating thing. We ask a simple question of does it matter? And I think, you know, I agree as you have, it's definitely a good predictor of risk, and we stare at this for our patients. And then it's good to see there's a lot of research still ongoing trying to refine, and it's maybe not, you know, treat the whole world. Statins in the water and, you know, HDL therapies may need to be more targeted.
And what do you think about, I mean, within the limits of your, you know, professional responsibilities, CETP inhibition, I mean, is part of anacetrapib going to be its LDL effects? Do you think that's going to be hard?
Well, it's interesting how, you know, with statins you have the LDL and the inflammation, and with the CETP inhibition, several effects of LDL lowering, HDL raising. There it's more than double. Also very modest on triglycerides, but Lp(a), and in the end we won't know. I think we'll plan to do a correlation curve to see if whatever benefit would it be explained by the LDL change, and if it's more than that, you'd say, well, maybe then it's HDL. It's hard to tease out with multiple lipid effects. Ultimately, we'll just simply hope that it does something as an add-on to statin, because it's been hard to find something that's beneficial beyond the statin so far. So,
well, it'll be exciting to see.
Well, I want to thank you, Jorge.
Thank you.
I want to thank Lilly USA, Amarin Pharma, Merck, and Amgen, who all supported this important educational series. Please remember to complete the quiz at the end of the session, and that gets you the CME credits. And stay tuned for the next session, which will be clinical implications of hypertriglyceridemia with Mike Miller and Dr. Blaha, filling in for Roger Blumenthal. My name's Chris Cannon. Thank you very much for joining us.